This is the BBC.
This podcast is supported by advertising outside the UK. This is the BBC.
Hello, thank you for listening to this edition of Inside Health. I hope you enjoy it. Coming up in the next half hour, antidepressants. Margaret McCartney takes a closer look at the research behind recent headlines extolling their virtues, and stem cell therapy to repair cartilage. I visit a centre harnessing the healing power of nature to help people with damaged knees. But first, diabetes, and new figures showing that the number of people with the two main forms of the condition in the UK has doubled in the last 20 years to nearly 4 million. And while 9 out of 10 cases are the type 2 variety, most commonly associated with being overweight and older, there's also been a worrying increase in the insulin-dependent type 1 variety too. Indeed, the UK now has one of the highest rates of type 1 diabetes in the world. And it seems to be developing earlier, with more young children being affected. Managing type 1 diabetes requires careful monitoring of blood glucose levels and constant adjustments of insulin and or carbohydrate intake to try and keep levels in the healthy range. Too high and it can make you very unwell and increase the risk of long-term complications like blindness and kidney disease. Too low and it can lead to coma, seizures and even death. So checking sugar levels using finger prick blood tests, often through the day and night, are a routine for many people with type 1. But new technology is changing all that and leading to a revolution in the diabetes world. Inside Health's Margaret McCartney has been learning more in her home city of Glasgow.
We can't say for sure why there's been a 5-fold increase in type 1 diabetes over the past 40 years. But what we do know is that it's easily missed, and once diagnosed, it is often challenging to manage. Around a third of children with type 1 diabetes aren't diagnosed until they're critically ill with extremely high sugar levels, a life-threatening condition called ketoacidosis. Dr. Kenneth Robertson is a consultant paediatrician who's led NHS Greater Glasgow and Clyde's diabetes service for children for the past 25 years. Good management of type 1 diabetes in childhood, he says, reaps rewards later on.
If you have good blood glucose control for a period of time, years probably, but certainly many months, it seems to reset something in your body, which means that even if you have a rocky time later on, let's say in adolescence, which is common, you have less complications than somebody who hasn't had that period of good control. And this is a big change, because when I was a boy and started looking after children with diabetes, there was a view that it didn't much matter before puberty. That has been completely squashed, and it matters a very great deal.
So for Dr. Robertson, here at his clinic at the Royal Hospital for Sick Children in Glasgow, careful monitoring of glucose levels in blood is the bedrock of good control and management of diabetes. But until recently, the only way to do that was by multiple finger prick tests using glucose strips, a minimum of 4 times a day, but often 10 times or more. It's a lot of finger pricking, and parents testify to the difficulties of doing that multiple times a day on their children, especially during the dip in blood sugars that usually happens overnight. So the development of new technology that remotely senses glucose, not directly in the blood vessels but in the tissues, using sensors placed under the skin, seems to be a game changer. Ben's young son George has recently started using a continuous glucose monitor, a system that alarms when blood glucose levels are dropping.
He's 6 years old, loves playing with Lego, and he'd had a really bad cold, so we were just finger pricking him every hour or so. We bought him a Lego set, and his fingers hurt so much he couldn't play with his Lego, and that was really what flipped us. We were looking at constant glucose monitors and the various options out there, and just decided to go with it after that, and it's an absolute life changer.
So what were you doing before that then?
Finger pricks.
Through the night?
Through the night, yeah. My wife's generally up 1, 3, 5. I don't know how she works on no sleep, but she's an absolute superhero.
So it sounds as though it's made a big difference to you. Are you paying for this just now?
Yes, and it is extremely expensive. The sensors are $205 a month, and then every now and again you have to replace the transmitter, which is another $75 or so. We're looking at funding, but it's a bit of a postcode lottery at the moment.
There's also a new, cheaper glucose monitoring system that's making a big noise in diabetes care called flash glucose monitoring. Freestyle Libre is the company involved, and unusually it was marketed directly to patients. It came on NHS licence at the end of last year, and Dr Robertson explains the differences between the two.
Continuous glucose monitoring and flash glucose use essentially the same way to measure the tissue-juice glucose. But the fundamental differences between them are that the flash glucose is not linked to anything, so it can't control a pump, and there are no alarms. And so the essence of the technology is that you have to swipe a reader across your arm, across the sensor, in order to pick up the data that are stored there. And it doesn't matter what the data show, if you don't swipe, you don't know.
I'm Matthew, and I've been type 1 diabetic for about 10 years, and I have the Freestyle Libre. It's like a wee cannula. You insert it into your arm, and then when you've done that, you can just scan your bloods anytime you want without having to finger prick all the time.
Can I have a wee look at your scanner?
Uh-huh.
So it looks like a iPod type size, like one of those mini iPod type things.
Yeah. So you press the wee blue button to scan. You just go over your arm.
Yeah. Through your clothes?
Yeah, you can do it through your clothes as well.
Wow, okay.
And then it tells you what your bloods are now, and it shows you a graph of how they've been over the past few hours.
Right, okay.
It means that at night I sit and check my graphs, and it means that I can change what insulin is adjusted if I'm running higher overnight or anything.
Do you still have to test your finger prick?
Yeah, you do it maybe about once a day.
Okay.
And if it comes up on it saying that your bloods are low, then because it's got a 15-minute kind of delay, so you do a finger prick check, and if you're low, then you have your Lucozade and your biscuits.
So it tells you what your sugar level was 15 minutes ago?
Yeah, and it gives you an arrow telling you like if it's going to be steady or if it's going to come down or go up.
And Barbara, you're Matthew's mum.
Yes. It's been life-changing. Matthew's quite a deep sleeper, so if we feel that his blood sugar's been a wee bit variable, then we can check him overnight, or if we know he's going to have a longer lie in the morning, then I can go in and scan him very early just to make sure that his bloods are okay and adjust if necessary. And the difference to his fingers has just been fantastic in just a few short months.
So would you stick with this then? Is this something you'd like to do?
Definitely.
Yeah. And are you getting this funded just now by the NHS?
No, I'm funding it myself. It's about £100 a month, but I'm really looking for the NHS to be funding it soon.
It's easy to see how people like Matthew are rightly enthusiastic about the life-changing impact of this technical revolution on the management and control of their diabetes. But can we demonstrate that this is an evidence-based, cost-effective spend?
The political pressure to fund these new technologies is great. And as a diabetologist who wants to have access to these technologies, I understand that political pressure. But as a scientist, as a professional, I have to be very careful that we don't just run between technologies, because otherwise we're going to be into a VHS Betamax type situation. And so just jumping on the next bandwagon is not a good idea, but we must implement these things well, safely, in a controlled way, and in partnership with our patients, who must use these things to best advantage.
Dr. Kenneth Robertson talking to Margaret McCartney in Glasgow. Despite this new technology being broadly welcomed by NICE and the NHS, there's currently marked variation across the UK when it comes to funding, even for those who meet the eligibility criteria for continuous glucose monitoring. And as we've just heard, some have even resorted to paying for it for themselves. It's a similar situation with the more recently approved and cheaper flash glucose monitoring. Nikki Jewell is Policy Manager for Diabetes UK.
There are some areas that have said absolutely no, they're not going to allow access for anybody at the moment. And there are areas where access is quite reasonable.
And looking across the UK, is any one country doing better than the others?
Wales were pretty much first and ahead of the game and more consistent, I think. And Northern Ireland managed to put together a system very quickly. In Scotland, we were told that they were waiting on a technology appraisal that's being done in Europe, But actually, Lothian have just announced that they're allowing access, and I think one of the other health boards too. We know that people are making sacrifices to be able to afford this. I've spoken to a mother who was doing extra shifts as a nurse so that she could afford to fund it for her child. I saw somebody this morning was saying that they'd spent £3,000 so far.
And what sort of benefits are they telling you that they're getting? Because, I mean, if you're spending £3,000 and you're having to work extra shifts, there's got to be some obvious tangible benefit.
Exactly. The things that people say are that they understand what's going on with their blood sugar levels, that they actually feel they're in control of their diabetes.
Because a lot of these patients are very interested. I mean, doctors and nurses might think they own diabetes, but the individuals own their own diabetes.
And that's really why we took it up as an issue, because people were coming to us and saying, this is one of the most revolutionary things that's happened in diabetes. It empowers us. You've
got a map where people can see what's happening in their area in terms of access. I mean, is there partly you trying to shame people into doing the right thing, as far as you see it?
Yes, we want to give information to people about what's happening in their local area, but there is certainly part of that is to say, look, next door, in the next area to you, they've got access and you haven't. So yes, there is a certain amount of that. We'll certainly be opposing blanket bans where this has been considered locally and a decision has been made not to allow access. There's no real justification for that.
And as far as you're aware, there are some parts of the country that have put a blanket ban on, or are they saying at the moment not in the foreseeable future?
It varies. Some areas have said that there's a ban at the moment until they've reviewed it and they're waiting for evidence or guidance. But these areas aren't so different from each other. So, the population of Hereford isn't that different from the population on the other side of the Welsh border. So there's no justification for that, really. So we will be opposing those. And then there's areas where they've said that they're not going to review it for a year. I think we would see that as unreasonable.
Too long.
Too long.
Nikki Jewell. Whatever the pace of uptake, most people in the diabetes world agree that it's the start of a revolution, a generational shift in the way blood glucose levels are measured. Dr. Partha Carr is Associate National Clinical Director for Diabetes at NHS England.
We moved on from dipping urine to finger pricking in the 70s, 80s, and this probably is the next generation of checking your glucose levels, so that's where it probably will stand over the course of time.
The flash technology has been unusual and it's been directly marketed to patients, and patients have run with it. I mean, a lot of them are funding this themselves. Does that concern you, or is it something we should welcome?
I think it's been interesting to see how it's gone, but some people have bought it, and as one of the roles of NHS England is to try and make the appropriate technology available to people irrespective of their ability to buy, and that's the ethos of the NHS. So with that in mind, we laid out the policy and negotiated it being on the tariff. That's what we're trying to encourage, is better uptake, irrelevant about whether it's being bought by people or not.
I get the impression, speaking to some patients who are using this technology, some of them are using technology that piggybacks on the back of it. They seem to be running away with it and far ahead of us doctors in many cases.
Absolutely. I think lots of people are looking into this technology. My personal view is that we should encourage this, and anything that keeps people better or keeps them safe. There is obviously the regulatory side of things which we need to be mindful of. But if patients are doing it and are better, there's something we all need to learn from.
Fears have been raised by some doctors, including Dr. Robertson, who we interviewed earlier, that we have to be careful that just because technology is new, that we don't jump on the wrong bandwagon. He used the example of Betamax and VHS, that we need to appraise this technology very carefully. We do need to proceed with some caution, do we not?
Absolutely. So it's a bit like buying a new car but without quite the skills to drive it. Any technology is as good as the person using it with the education base they have. So when we're talking about flash glucose, the guidelines published is very clear that this should be given to people in whom they have some level of education, the healthcare professional has the education, the patient has the education, and most importantly shows some benefit. So there is a trio of conditions there as well, which makes sense, and quite rightly too. Technology, as you say, needs to be used based on the education you have.
From a purely cost basis, I mean, and there's no such thing as an average person with type 1 diabetes, but from a purely cost basis, if I'm testing, say, 8 to 10 times a day, is this likely to cost that much more?
No, I think that's where the national guidance has been set, that if you're testing more than 8 times a day, it's looked to be cost neutral. As regards other costs, if you improve your quality of life, if you improve your admissions, or be able to stop yourself from going into lower blood sugar readings, then we would expect some more financial benefits over the course of time.
Is there any evidence yet that this sort of monitoring improves control to the extent that we might reduce the risk of medium to long-term complications, which in themselves are very costly, not only to the individual, heart disease, stroke, kidney problems, eye problems, but also very costly to the NHS?
Yes, there is a real-world study done in about 50,000 patients who have used flash glucose monitoring. And if you look at the data, it clearly says that there is a significant drop in HbA1c, or the marker for diabetes control. And the important thing there is the more you scan, the more you seem to improve your overall control. So evidence is accumulating. And most importantly, as we have started to encourage more pickup of this technology in the UK, we have also encouraged that a national audit be done, and we'll be analysing the data hopefully to see what benefit it shows, and glucose control will be one of them.
Diabetologist Partha Carr, ending Margaret McCartney's report on how technology is changing diabetes. Margaret's in our Glasgow studio now because she's also been taking a closer look at the research behind recent headlines about antidepressants. A large meta-analysis of over 500 clinical trials of the drugs, published in The Lancet, concluded that they work well, and resulting media coverage suggested more people should be taking them. Some of you have asked if the study was funded by pharmaceutical companies. It was not. Others, including Dr. David Stevenson, have been in touch to point out that this research centred on major depression, not the more common mild to moderate forms. Margaret?
Well, that's a really good point, and this study hasn't got full information about which patients are most likely to benefit from the drugs. And while I have no doubts that they do help some people, we also have quite clear evidence that they don't make a big difference to the vast majority of people with mild to moderate depression. And that's why NICE, for example, don't recommend that they're used first line for people with mild depression. They recommend other treatments instead. And this study, of course, only looked at antidepressants as a treatment for depression. They did not look at the psychological interventions that we know work really well, at least as good as or better than antidepressants for many more people.
One of the surprising findings for me was the difference in how well these drugs worked. I mean, looking at this meta-analysis, amitriptyline, one of the oldest antidepressants, came out way on top, whereas citalopram, that's one of the newer generation of Prozac-type drugs, came close to the bottom, and that's the one we're using mostly these days.
Yes, I mean, one of the reasons why we don't use amitriptyline so much now, I think it's twofold. One is it's what I would describe as a bit of a manky drug. It's got lots of side effects, for example, sedation, constipation, dry mouth, people just generally not feeling great on it at the high doses that we need for depression. We still use it quite a lot, but in much smaller doses for chronic pain. So that's one of the reasons why we don't use it so much. And the other reason is that it's very, very toxic in overdose. Many fatalities due to amitriptyline taken an overdose by people who were depressed has largely been avoided now because we hardly use it for depression.
But the takeaway message from this research is that the modern drugs may be better tolerated, but they're perhaps not as effective.
The researchers tried to look at this in terms of a sliding scale of effectiveness, and one of the methods they used was depression questionnaires, asking people to plot on a tick box questionnaire how bad their symptoms were and then giving them a score. And you can have high statistical significance when you get clear differences between the drugs in terms of what the questionnaires showed, how many points people got from their depression score, to say that one is different from the other. But these might not be clinically significant. So a small change in points might be statistically proven. It might be something that you're quite certain about looking at the analysis, but it might not make a really big difference to patients. And that's the bottom line. Are these drugs clinically effective enough for people to put up with the side effects?
So these differences might not translate into real-world benefits. And talking of the real world, the other thing that struck me about this was the average duration when they looked at the antidepressants in the study was just 8 weeks. And you and I know that the average course, in fact the minimum course, is probably something more like 9 months.
Oh, at least. And one of the big problems that we have as yet unanswered is what is the effect of taking these drugs perhaps on and off, or mainly on for years at a time. And that's where we have real deficits in our information. It's really tragic that so many trials have been done looking at the short term when the real life use is of months and even of years. It's really appalling that decades have passed without us asking the fundamental questions of how we're using them today and whether that's safe and effectively good practice or not.
Thank you, Margaret. And for those of you keen to do your own critique, there's a link to the Lancet antidepressant meta-analysis on the Inside Health page of the Radio 4 website, where you can also subscribe to our podcast service, meaning you'll never miss an episode again. Nearly 200,000 hip and knee replacements are performed every year in the UK, the vast majority of them on middle-aged or elderly people with osteoarthritis. What if we could repair damaged cartilage in younger people and prevent them developing arthritis that requires a new joint later in life? Well, that's one of the aims of researchers harnessing stem cell therapy to grow new cartilage to reline damaged joints. But it's a complex process that up until recently has involved two stages. One, to harvest the stem cells and grow them into cartilage, and another to put the new tissue back into the injured joint. But now a team at the Royal National Orthopaedic Hospital in Stanmore has developed a one-stop operation that means the stem cells can be collected and put back into injured knees within a couple of hours. George Bentley, Emeritus Professor of Orthopaedics at University College London, has been leading the work.
Yes, well, in the knee, the surfaces are lined with articular cartilage, which is unique in the sense that it's extremely tough. Now, the problem is that there's no blood supply, nor even nerve supply to the cartilage. And so if it gets damaged, it doesn't repair. So it's crucial for the joint. And if the cartilage breaks down for any reason, then the joint becomes painful and gradually and progressively deteriorates.
So the function of cartilage in the joint, it's a sort of slippery, resilient, slightly softer surface than the bone that allows the joint to work smoothly.
Yes, and it's extremely slippery. The normal joint is probably 3 or 4 times more slippery than the best artificial joint that we have.
So because it lacks blood supply, cartilage doesn't repair itself effectively. So as a result of injury or other disease processes, if you get a defect in your cartilage, you're in trouble.
Yeah, absolutely.
My name is James Donaldson. I'm one of the consultant orthopaedic surgeons at the Royal National Orthopaedic Hospital in Stanmore. We're talking about the articular cartilage, which is the end of the thigh bone in the knee and the top of the shin bone in the knee.
How would people injure that?
It can be from trauma. So one of the commonest reasons is an athlete that damages their knee. Everyone knows about damaging the ligaments or the meniscus, but what isn't fully appreciated is an injury to the actual articular cartilage, the lining of the knee joint. In the past, the treatment of that has been less effective. One of the techniques is to drill into the bone and encourage healing with scar tissue, which is what we call microfracture. That heals with a fibrocartilage, which isn't as mechanically sound as normal articular cartilage.
It's a sort of scar tissue.
It's a scar tissue. It's a scar tissue repair. That does give symptomatic improvement for about 5 years, but after that the results tail off, and then they end up again in the osteoarthritic situation, requiring further surgery.
So I'm approaching 40 this year, and in my early 30s I started to get a lot of knee problems after playing rugby my whole life, basically, just through wear and tear. I had a couple of cartilage operations, but nothing seemed to really work. And then the doctor said to me, your next step really is to have your whole knee replaced. And as a 30-something chap, I was thinking, this is not looking good. I really want to try and do everything I could to not have to go through that at such a young age.
Everybody knows that stem cells can grow into any sort of other cell.
Sort of universal.
Yeah, universal donor cell, yes. I mean, it can be neurological tissue, or it can be nerve tissue, or it can be cartilage. And so what we do is we take cells from the bone marrow, which is within the bone of the pelvis. And when you centrifuge it, you can recognise a layer of cells which are precursors of the stem cells. And so we separate those out. We also use a hyaluronic acid matrix, which is a meshwork, and we put the stem cells, precursors, into the matrix, and it takes about 30 minutes at maximum to prepare this blood and stem cells and then the matrix. And so in the meantime, we open the joint, clear the defect, and where we had put in cells by injection before, we now put in this matrix with the stem cells. The advantage of that is that it's also very quick, because you can actually secure this transplant of cells and meshwork with glue. And so you don't need to do any suturing. And so the procedure with all of that I've mentioned takes probably a maximum of an hour and a half.
Media reaction for a lot of people is what you're going to have like a mouse growing an ear on the back or something like that, like some sort of Frankenstein operation. But as I read more and more about it, it's actually, you're using your own cells to repair your own body. So my head got around it quite quickly, I think, and I realised actually this is a great idea, a great opportunity, because if my only other opportunity is to have my knee replaced with metal, which would then have to be replaced again in 10 or so years' time, let's give it a go.
We have data coming up to 18 months to 2 years now, and in the correct patient, the results are comparable to the two-stage process that has been written about in the literature. The results are probably in the region of 75% effective in reducing patients' pain and improving their outcomes, so improving their function.
You're a specialist unit here, you've been involved in the research. I can see your patients having access to it. What about people in other orthopaedic units across the country?
Regenerative cartilage procedures are expensive or have been expensive in the past. NICE, so the National Institute for Clinical Excellence, has recently said that autologous chondrocyte implantation is a useful first-line procedure for a cartilage injury in a young patient. That procedure, the ACI, costs in the region of £16,000. We have moved on slightly from that, doing this in a one-stage procedure, and we think we can reduce the cost of the procedure to about £3,000 or £4,000, although any of these procedures are done in specialist units and they need to be done as part of a research trial so that we can monitor the patients, ensure the right patients are having the right operation and looking at the long-term outcome.
Came out of the operation and just did a leg brace, like fixed leg brace, a leg out straight. It was just like that for a couple of days, and then they fitted me with a hinged, like Velcro leg brace, and encouraged me to move the leg as much as possible. But it was, 3 months non-weight bearing, so not putting any weight through my leg. And then after 3 months, it was do partial weight bearing, so that's walking with crutches and putting 50% weight through it. And so it was a slow recovery. That's about 6 months before I could properly walk without crutches.
From a personal and professional point of view, I mean, how do you feel about the procedure? It feels a bit like a dawn of a new horizon. We've been there before, though.
We've been there before, so there's always dawns of new horizons in medicine. I think medicine and particularly orthopaedics are going to go down a regenerative route, looking to the future and trying to delay the need for more expensive and invasive procedures like joint replacement surgery. So it's not just the knee that this is applicable, so foot and ankle, shoulder all have very similar cartilage defects, and if we can show this is a useful tool, a useful procedure with long-term data, then it can be applied in all parts of the body.
My father had really bad rheumatoid arthritis, so he could never run around with my brother and I when we were younger. And so one thing in my head was I really want to try and be able to run around with my little boy. And so now, I can do that. We go to rugby training on a Sunday morning. He's only 4, but he gets involved in rugby tots, and it's just great to be able to experience this growing up with him. And I can run for a train if I want to. I could go dancing with my wife if I want to. The physio said I can start skiing again, start jogging. So it really has gone from just being able to walk in lots and lots of pain and have to take ibuprofen and paracetamol quite regularly to move at any speed I like to now. It's really changed my outlook on life, really. So, I'm really pleased with it.
Nick Brown, who seems very happy so far with the experimental new stem cell treatment being trialled by George Bentley, James Donaldson and the rest of the team at Stanmore. Just time to tell you about next week when, among other things, I'll be finding out why half the people who have heart attacks in the UK are still missing out on an established therapy that could dramatically improve their odds of survival. And it doesn't involve a pill. Join me then to find out more. Thank you for listening. For more information on this programme or for other Inside Health programmes, please visit the Radio 4 website.